Welcome to the virtual rounds today. I'm so happy to see all of you guys here. I'm just going to give a couple more minutes to see if anybody else joins. But in the meantime, I think I might give us another 2 or 3 minutes if that's all right with everyone, and then we'll get started, okay? Just while we're waiting to see if anybody else shows up, let me know if you weren't able to access the SOAP note. It's a good idea to maybe have it pulled up while we're going through the case, just so you can fill out all of the different portions. All right. Can everyone hear me? Can someone respond in the chat just to see? Awesome. All right. Thanks, guys. So hi, my name is Jackie. I am a third-year medical student down in Florida right now. I am passionate about surgery and cardiac surgery and cardiology. So I'm very excited to be giving this talk today about postoperative fever. I will be asking for participation while we're going through this, but I will never cold call anyone. Feel free to unmute and answer, or feel free to send answers into the chat. You can also directly message me if you're not comfortable with the group seeing your answers, whatever is best for you. You guys can't see the chat blocking the screen, can you? Can you see the full screen? Yes. Okay, perfect. So with that, awesome. Thank you guys. So with that, we're just going to get started. Stop me if you have any questions at all. And we'll just get started. Okay, so this is the cast of a show. I talk about this show a lot. This is not going to be a talk about Grey's Anatomy, but I promise that this ends up being pertinent later. If you've seen the show, hopefully you'll see where this all is going. So for the session outline, we're going to start with the case, physical exam, differentials, assessment plan. I'm hoping that you guys participate, and I'm hoping that you can fill that SOAP note out as we go. So here's the SOAP note. I like to do a little review before we go through it, because I feel like sometimes people don't really know what we're putting in each of these sections. So just really quickly before we start, can anyone tell me what belongs in the subjective section of the SOAP note, just to the best of their knowledge? Chief complaint, perfect. That's absolutely right, Seema. So I'll say this, the subjective part of your note, and this is going to apply, I assume a lot of you guys are probably applying to medical school. So if you are, then this is really, really going to be pertinent. You'll do SOAP notes on almost every patient you see. So subjective means that it's something that the patient says directly to you. So this is going to be, like Seema said, the chief complaint. HPI is the history of present illness. And so that's when you say, what brings you in today? That's everything that they're telling you is bringing them in. The ROS is the review of systems. So again, that's saying, do you have a sore throat? Yes. Do you have a runny nose? Yes. And so these are all coming directly from the patient. Now, On the other hand, objective, does anyone want to take a stab at what will go in there and how is that really different than subjective? Vitals, things we can measure and see as the physician. Perfect. Both of you guys nailed it. Seema and Catherine, perfect. So objective is now going to be things that we are observing as the physician. So now it's going to be, as you mentioned, vital signs, physical exam. So rather than saying abdominal pain would abdominal pain go in subjective or objective? Subjective, perfect. Yep. So abdominal pain would be a subjective finding, and then the objective finding would be I press on the abdomen and I'm appreciating abdominal tenderness. That's something that I'm observing. Additionally, in objective, we would put labs, we would put imaging, we would put things like that. So those are all things that are not dependent on what they say. And then finally, the assessment and plan. I hope this makes sense to everyone. If you've already heard this a million times, I'm sorry for going through it, but I know sometimes there's a little bit of confusion. So I just wanted to clarify that before we get started. All right, so here's the case details. These are all stock photos, by the way. I promise I didn't just take pictures of random patients in the hospital. He looked appropriately sad. I felt like he might have been a good choice. So we have a 66-year-old male here, post-operative day 3. We abbreviate that as pod 3. Following a coronary artery bypass grafting, also known as a cabbage, and he's now recovering in the cardiac ICU, and he has developed a fever of 102.2 overnight. What other questions would you like to ask the SICU nurse about the patient? Five W's. Adam, I know exactly what you're talking about. I promise we'll get there. Any pain? Tisha, that's great. So we definitely want to ask if the patient is having pain. If they're having pain, where is the pain? Anything else? Vitals, yep, we definitely want to assess the vitals apart from the fever. Does anyone know how we define fever? A lot of people will say like, I have a fever, but it's subjective. What is the actual definition of a fever as far as numerically? $98.8, 100, over 101. Yeah, close. It's 100.4 is going to be where we define a fever. So this guy's definitely febrile. I see a lot of people come in and they'll be like, I have a fever. And I'm like, what's your highest temperature? And they go 99. I'm like, oof, you are not feverish. So that's not a fever. I just wanted to clarify that. So, but you're right, Seema, we also want to do that review of systems. We want to see, are you coughing? Do you have any nausea? And you might be asking these questions because these are common symptoms, or you might have a specific diagnosis in mind, which would be even 2 steps ahead. Anything else we want to ask the SICU nurse? Condition of a surgical incision. Destine, that's a great idea. We absolutely want to ask about how the surgical incision looks. And even more than that, we're going to go look at it too. Has anybody had contact with the patient? Avin, that's a great idea. Absolutely. If a bunch of people have been in there, that might be like a sick exposure. Absolutely, we want to see what medications they're on. Could he be having a reaction to one of the medications? Maybe he's allergic. Great questions. Anyone else before we keep going? These are all great. I already clicked it. Sorry. So this is our SICU nurse. He's just chilling. These are some questions that I had come up with, but of course you guys covered a lot of them. So we want to ask about pain. Is he having trouble breathing? I want to know if he's got any lines or drains in, and we'll get to why that's important in a second. Lines and drains, meaning does he have IVs? Is he getting fluids? Does he have a Foley catheter in? Is he getting antibiotics? You guys mentioned medications already. We want to ask if he's been walking around. It's post-op day 3. Has he just been lying in bed, or has he been moving over to a chair? And how long has he been in bed? Prior to the surgery, was he bedbound, or was he walking around and then he came in for the surgery? We'd like to know that too. We want to know about his medical conditions, prior surgeries, and then we want to know if maybe he smokes. Why is maybe smoking important? Smoking affects wound healing. Perfect. Yeah, you guys are already way ahead of the game. So it definitely affects wound healing. Smoking adversely affects just about everything. Don't smoke, kids. And also that might make his lungs weaker. You know, he might be more susceptible to wound pathology, lung pathology. And then, as you guys mentioned, has he had any sick contact? Maybe he was just visited by his great Aunt Marge and she's got tuberculosis. That's a bit of a stretch, but maybe he has sick contact. We're not sure about that either. We want to know if he's immune compromised. Does he have HIV? Does he have any chronic conditions? Does he have cancer? We'd like to know these things as well. So I've asked all of these questions kind of with specific diagnoses in mind, and I hope that as we go through this chat, it will start to make sense to you kind of why we're asking these questions. But you guys really did an amazing job getting most of them. So now we're going to move on to the physical exam. As you guys mentioned, we definitely want to examine the patient. Let me know if I'm going too fast also. You guys are probably putting this in your SOAP note as we're talking. So vital signs, 102.1 at the moment. What's the pulse like? Is this normal? No, it's not normal. He's a bit tachycardic. Upper normal is what? Anyone? Guessing is fine. 80 is a great guess. Yeah, so 100 is technically the top. We want to be anywhere between 60 and 100. Below 60 we call bradycardic, and over 100 is tachycardic. So he's a bit tachycardic here, a bit fast. His BP is just a touch low. Normal, does anyone know what normal is? You guys aren't responsible for knowing these values, just if you happen to know. Exactly, Seema. Yeah, so it's 120 over 80 is like perfect blood pressure. I certainly don't have that. Respiratory rate, it's a little high, but it's pretty much fine. And he's setting 97 on 4 liters of nasal cannula. And for those of you who don't know, nasal cannula is that like clear tube that runs under the nose and then has the 2 little things that go in the nostril. So we're just running oxygen up into his nose basically. And he's setting 97, which is a little low, but he just had a big heart surgery. So he's appearing unwell. He's diaphoretic, which means he's kind of sweaty. He's sitting up and leaning forward in bed. We go bring our stethoscope, we listen to his lungs. His lungs are clear bilaterally. He's got no wheezes, rubs, or gallops. This should say wheezes, rubs, or rhonchi. Please correct that. Gallops is a cardiac finding, not a lung finding. He's got a triphasic rub at the left lower sternal border, no murmurs, tachycardic, regular rhythm. Chest is non-tender to palpation. Skin is diaphoretic, which means he's sweating. He's a little pale, but he's got no lesions or ulcers that we can see anywhere on the skin. We did a full skin check. And he's got a well-healing sternotomy scar. I know someone mentioned we got to ask about that incision. That is clean, dry, and intact. Now, does anyone have any questions about any of these findings? I'm happy to come in and explain them. What's a triphasic rub? That's a great question. So there are a couple things that we listen for in heart, and I've given a number of talks about heart stuff. And since I'm feeling like I'm seeing a group of new people, if any of you guys want me to repeat talks that I've given in the past about, I've given a talk just about general heart physiology and kind of how the electrical system works, how the chambers work. I'm happy to give that talk again if I'm seeing new people here. Let me know if there's interest in that. And I can go very, very deep into this heart stuff. It's my favorite thing to talk about. So triphasic rub basically means it kind of almost sounds like sandpaper. And so the heart beats in 2 phases, one when it contracts called systole and one when it relaxes called diastole. And basically if the heart, you're kind of hearing the heart rub against the sac that it sits in, which is called the pericardium. You're hearing it kind of rub against that pericardium as it's beating. And it's triphasic because that as it's beating, it kind of scrapes against the outside of the pericardium, or the inside of the pericardium rather, as it's beating 3 times. And this is pretty pathognomonic for a specific condition. Don't go Google it right now. We're going to talk about it. That's not really the most important part of the talk. But So that's kind of what we're seeing. And that's at the left sternal border. So the sternum is right here. It's the thing that connects your rib cage in the middle. So it's to the left of it towards the bottom. So right kind of there where the heart sits. Murmurs are indicative of valvular pathology or abnormal flow. You learn in physics that there's laminar flow, which is that straight flow, and then turbulent flow, which is where there's kind of those like little swirls of fluid. And that just means that the fluid's running into something, and that thing it's running into is typically a valve that's not functioning properly in the heart. So this basically, when I see no murmurs, I see, okay, so the valves are all probably fine. So that's just what that means. So great question, Seema. But he is tachycardic, but he's got a regular rhythm, which means that he's got no arrhythmias, like the ones that you might have heard of, maybe AFib, VFib, things of that nature. So his heart is beating fine, and I'm pressing on his chest and it's non-tender. It probably actually should be a little tender because he just had a surgery, but he's not super tender. Any other questions about this physical exam findings? All right. So we also notice, as we're here with the patient, that he has a Foley catheter in place. Foley catheters help patients urinate. They're just chilling up there. And he's had it in since the procedure, and we checked the Foley bag, and he's been urinating clear yellow fluid regularly. So he's not having any obstruction. It's not bloody. It's not super dark. So this is all, nice. He's not passed a bowel movement since the surgery, and he's not been ambulating. He's just been lying in bed completely since the surgery. He has not had much of an appetite. He only ate a little bit of toast for breakfast this morning, and he's trying to drink, but he says he's not very thirsty. And he'd like to talk to the cardiac surgeon who operated on him again, or anyone, because he feels like his chest is kind of starting to hurt a bit. That's why he's kind of leaning forward. So this actually, I've gone a little bit out of order, but this is kind of, this is a bit more this is kind of a mixed bag of subjective and objective. So like this bit right here would be considered subjective, and pretty much the rest of this is going to be objective, but you could probably stick this in the HPI if you like. Is the pace I'm going okay? Do you guys want me to slow down, speed up, anything? Good pace. Awesome. All right, we're gonna keep moving. So here's our differential. We got kind of two problems here, so I think we're gonna take this differential diagnosis in a two-pronged way. So he's got that chest pain. So we've got a couple different things that the chest pain could be. It could be cardiac chest pain, or it could be non-cardiac chest pain. You know what? I should go back. Does anyone want to start throwing out? I know you just saw kind of what I had thought, but I didn't build a completely comprehensive list. So does anyone want to start throwing out some things that they think might be causing this guy's chest pain? It's okay if it's something that was just on the slide in front. No answer is a wrong answer. Clots. Wonderful, Josh. Clots is a great answer kind of for everything, because he's got a ton of risk factors for clots, because he's been sitting, he just had surgery. Clots is an excellent answer, and that could absolutely be, as Adam is saying here, occlusion of the coronary arteries, also known as an MI, or myocardial infarction. So you guys together have one of the best answers, which is this chest pain could be caused acutely by an MI. Infection of the heart from the IV line. This is great. This is kind of a multi-level answer. He's got those lines in. I know we mentioned, does he have any lines or drains? Great. Do you know what this infection to the heart is typically called? Endocarditis. Wonderful. You guys are basically doctors already. So endocarditis is what that's called. It absolutely could be coming from the IV line. That's one of the reasons that like IV drug users are a huge at-risk population for endocarditis. But most commonly, it actually comes from poor dentition, or like people who don't take care of their teeth are getting endocarditis. But does anyone know, this is kind of a high level question, but I feel like you guys are up to the challenge. Does anyone know what what in his physical exam findings that I can go back makes me think it's probably not endocarditis, which is going to be infection of the valves of the heart. Anyone know? It's kind of a no murmurs. You guys are amazing. Yeah, exactly. He's got no murmurs, and typically we're going to hear some sort of murmur if he's got endocarditis because he's got vegetations on the valve, and so typically we're going to hear that turbulent flow. You guys are amazing. So that's a great one. Adam said pericarditis, and I gotta say, Adam, I agree with you. This triphasic rub is very, very, or even they'll just say it's a rub, but I'm being a little bit more specific. Hearing this rub is definitely indicative of pericarditis, which just means that that sac that I talked about that is surrounding the heart gets infected. And so as the heart is beating against that kind of inflamed, infected pericarditis, it literally rubs against it and it sounds like sandpaper and it's very off-putting. Is it pericarditis when it's the outside? Justine, do you think you could be a little more specific? Outside of what? Outside of the heart itself? Oh yeah. The answer is type. Okay, yeah, so pericarditis is the sac outside of the heart, exactly. So when it's the heart muscle itself, it's a great distinction, Justine, is called myocarditis, different than pericarditis. The cheat in medicine is if you don't know what inflammation of the something is called, just add itis to the end of it. So pericarditis is probably what this guy has, but the differential is still very wide. I agree that MI is the first thing we should always think of when coming up with a differential is what's going to kill them first. He's not going to die from pericarditis immediately, but he could die from an MI. So you guys are great to kind of be mentioning all those things. But now let's get to the meat of the topic today, which is what do we think is causing this guy's fever? It could be secondary to the pericarditis, but it could also be any other number of things. So what do we think is causing this fever? Appendicitis. Josh, it definitely could be appendicitis. Can you talk me through why you think that might be the case? Just throwing something out there. You know what? I appreciate you. Yes, appendicitis can definitely cause a fever. He would probably have abdominal pain. And it's, I think it's pretty unlikely to occur right after a surgery like this, but that's not to say that it couldn't happen. So we want to look for pain down there in the right lower quadrant for sure. UTI, does he have pain while urinating? This is a great one. And he's at risk for UTI because what? Because he's got the catheter in. Exactly. He's had this catheter in for 3 days since he had the surgery. So we do want to ask if he's got pain while urinating. Now, it might be hard for him to tell because sometimes when you have a Foley catheter in, they're not really urinating like consciously the way that we do when we don't have Foley catheters in. He could just be kind of letting the urine come out without doing anything. So it's hard to say, but we would definitely want to do we definitely want to check for that. That's a great one for, what am I trying to say? That's a great differential for fever. Anything else? No answer is a wrong answer. I like Josh's energy. Let's just throw some stuff out there. Nope, there's no bad answers for what could be causing fever. We're taking a very, very broad approach to this. We're hitting this in broad strokes. We can even go back to some of these questions that we asked here if this helps to prompt any ideas. Foreign object left in during surgery. Emily, I like your train of thought. Yeah, we definitely want to check for that. Fun fact, do you guys know how they can tell if there are towels left in the abdomen nowadays? This is kind of a fun fact if you want to surprise your friends and families. No? Okay, so typically a lot of the those like cloths that they use, yeah, we do imaging. So they definitely count them. They do counts constantly during surgeries. I don't know if anyone has maybe shadowed or seen other surgeries. They're doing counts constantly, but a lot of them actually have a little bit of metal like somewhere in the corner. So when they do a post-operative x-ray, they can actually see like, oh no, like our count was off and I see the corner of that, lap pad there in the abdomen, and they can actually see it that way too. Because I guess it's happened far too many times. So Adam, you're right. We want to ask if he has gastric distress, and that could be for any number of things. Remember that he also hasn't had a bowel movement in 3 days since the surgery. So we definitely want to ask about gastric distress, and that could say, I mean, it's a little high. He had a sternotomy, but abdominal pain and chest pain can often mimic one another. So that's a great question too. What about some of these, like the walking around and lying down? Why are we asking about that? DVT, yeah, exactly. So we want to see if he's been clotting down there in the lower extremities, and certainly laying in bed, we call that stasis of the blood, can definitely cause clots. Also, I asked how long he's been lying down, and this might be a little bit harder. So I'm going to point down here to this. No lesions or ulcers. So if you're lying in bed, you can get what's called a pressure ulcer on the back, and that can cause infection as well. You guys are doing amazing. So here's what I had thought. Here are some things that it could be. These are kind of some cardiac pathologies, and these are some non-cardiac chest pains. So costochondritis is inflammation of the muscles that kind of support the rib cage. And that's typically pain that if you were to press on someone's chest, that they would have. Pain, we call that reproducible pain. That's that when you press it, it comes back. And mediastinitis, the mediastinum is the chest cavity here. And so if you were to have a deep infection of those tissues, like from the surgery he had, that could also be causing his chest pain. We talked a bit about these, the post-operative infection, perhaps hospital-acquired infection. We talked about that Foley catheter or the IV line. We talked about what else causes fever. So I think we pretty much covered this, guys. So here's our assessment and plan. So first and foremost, I want to cover the chest pain. So we're going to run an EKG, troponins, and an echo. EKG is going to be the quickest way to identify if he's got what? MI. Perfect, Andrew. So we're going to see if he's got an MI, if he's got what we call an ST elevation MI. If you guys ever want me to run a how to read an EKG session, I'm happy to do that. It's pretty fun. And we can go through this in detail. So we can also see if he's got an NSTEMI. So that's going to be a non-ST elevation MI. So we're not going to see those classic tombstoning patterns. But we will see elevated troponins in both of those cases. And troponins are enzymes that are in the cells of the cardiac muscle tissues. And so when the cells of the heart are not getting oxygen, what happens to cells when they die? Scarring? Yeah, they can scar. And Josh, you're right. They lyse, they apoptose. So they blow up and they release all of their innards, which will include troponins. So that's why when we see elevated troponins, we always get these in patients we're considering have an MI. We'll check for elevated troponins to see, are their cells dying? Is cardiac tissue dying? Which means it's ischemic, which means it's not getting oxygen, which means something's blocking those blood vessels. Echocardiogram with Doppler, we might want to do this too. This is if we were suspecting maybe endocarditis. So this is when they take kind of that ultrasound machine and they put it on the heart, and we're seeing a dynamic picture of the flow. This can help us as well. Also to look for tamponade, which is, I talked about that sac around the heart, the pericardium. If the wall of the heart were to break, we can actually collect blood outside of the heart, between the heart and the pericardium, and we call that cardiac tamponade, and that can be extremely deadly. So now fever, I want you guys to help me build this assessment and plan for how we're going to work up this fever. We talked about a million different things that could be causing this fever, but we don't have unlimited resources as doctors. We can't order every test in the book, or we will get fired, or we'll get yelled at by patients for them having exorbitant hospital bills. So we need to make a pretty focused fever workup here. So I figured we're going to put a pin in this, and after we kind of talk through the teaching point for this session, we'll come back and we'll build that together. So pathology. Here's some of the timings for post-op fever. I took this directly from a site called Up to Date, which if you go into medicine, you'll probably use. So we're not going to go through this in detail because you guys know how to read a graph. But here are just some of the common things that cause post-operative fever. And as you can see, the timing kind of varies between each of the different pathologies. They don't all happen at the same time, which kind of helps us to build a better picture of what might be going on. So I might not be testing for, superficial surgical site infection on day 1 because it's going to be less likely. So now you're thinking to yourself, how am I going to remember all of these lines of the graph and all of these causes and stuff? And the answer is, of course, Grey's Anatomy. Just kidding. The answer is, of course, Grey's Anatomy. There's a scene in the show, which is why I brought it up at the beginning, when they're pimping the main character and she spits out this wonderful line about the causes of postoperative fever are, someone mentioned it right off the bat, which means you knew exactly where I was going with this. And the mnemonic is wind, water, wound, walking, wonder drug. These are the 5 W's. Welcome to the game. There you go. There you go. So I have seen this entire show and I don't care. And I plug it shamelessly. And it's not realistic at all, but it's good drama. And I think it's good for this. So we have that. So now we're going to talk about them. So pathology, we're going to talk about wind, water, wound, walking, wonder drug. And this is roughly the timing of when they happen. And the great news is they tend to kind of happen in order for the most part. So in these first couple of days, it's going to be wind, then water, then wound, then walking, then wonder drug. And we're going to go through each of these now. So what does wind mean? Wind means air that we're breathing. So that means lungs. We're thinking pneumonia. We're thinking aspiration. We're thinking pulmonary embolism. We're thinking atelectasis. So now I want you guys to tell me, if I think that it's post-operative day 1 and he's got a fever, what would you like to do to work up this patient, this hypothetical patient on post-op day 1? What are some of the labs you're going to do or the imaging? Chest x-ray. I know that's a bit of a cheat because we have a chest x-ray here. But yeah, we have this right here. This is a big pneumonia right there on that right chest. Josh, you're right. We can definitely do a CT scan. And we're going to do a specific CT scan called a CT angiogram. And angio means vessels. So we're going to look at the vessels of the lungs. And does anyone know what we're looking for specifically if I were to run a CT angiogram on this guy? PE, yes, because a PE is a clot that usually travels up from the legs in the veins and goes up into the heart and out the pulmonary artery that goes into the lungs, and it gets stuck there. And that can cause rapid decompensation of the patient. So we do a CT angiogram to look for pulmonary embolus. Absolutely, that is what is going to kill your patient immediately. They're not going to die immediately from pneumonia. They're going to feel like crap, but they're not going to die. PE will kill them. So that's a great thing to check. Oven, UA, you're a little ahead of the game. I don't know if I would necessarily run a UA for these pathologies, but we definitely would like to run a UA for some of the other ones. I don't know what it's called. It's a breath test. I think you might be talking about pulmonary function testing, Adam. And that's something that we can definitely do. So we can do pulmonary function testing. We usually do this to distinguish between like restrictive lung disease and like asthma or COPD. Yeah. So you'll see people do this for like asthmatics or COPD people to see kind of, are your lungs hyperexpanded or are they really constricted? So we could definitely do that for atelectasis. You might also be talking about spirometry, which is, you might have seen if you've ever been into a hospital to visit someone who's there, you're probably going to see this like clear box-like thing with a tube sticking out, and the patient holds it and they have to like suck in, and then a little thing goes up to show you how much force with which they're sucking in. And that tells you, that helps to actually expand the lungs out, and that's to prevent atelectasis, actually. But a lot of people think that you're blowing into the tube. You're actually sucking in through the tube. So that's something I embarrassed myself with on the wards. I was like, blow into the tube, and I got absolutely ripped apart by my attending. Do you perform all the imaging at once, or do you pick one based on the patient's condition? This is a wonderful question, and one that more people should be asking, because you should not be necessarily ordering them all at once. Like I was saying, I think that the best approach is to use your clinical judgment. Like, we're not just going to say all of these are equally likely, because they're probably not. The cheapest thing to do first is probably an X-ray, but a PE, which is what's going to kill them, is not going to show up on X-ray. And so I might prioritize the CT angiogram to look for that here. And there are some blood tests you can run as well to confirm a PE. But in real life, the first thing they're probably going to do is a chest X-ray, because it's cheap and quick, and then we can rule out pneumonia very quickly. We're also going to listen to his lungs, and typically if he has pneumonia, which is the first and cheapest thing to do, the answer is always to do a physical exam. If he has pneumonia, we're going to listen to his lungs, and we'll probably hear that there are crackles somewhere in the lungs, and then that would make us want to do a chest X-ray. I would prioritize probably first the thing that's going to kill them, which is going to be the CT angiogram. That's a great question. Any more questions about wind? We got 4 more. Nope. All right, water. Now it's time for you, Avin. This is what the UA and the UTI associated with catheters. This is what the catheter looks like. We've put this part into the urethra, and then we blow up this little balloon, right, which here is right here, and it just kind of keeps it in place. And so this balloon has been in our patient for a lovely 3 days. So how do we want to work this patient up for a UTI? It was already mentioned. I just said it. I don't want to insult your intelligence. It's a UA. It's a urinalysis. So does anyone know what we're going to look for on the UA? This is an advanced question. Does anyone know what we're going to look for on the UA to see if this patient has a UTI? Bacteria. Yeah, we can definitely culture the urine. And if it grows anything, yeah, Catherine, you're absolutely right. We're going to look for leukocytes, and we're going to look for some different proteins that imply certain types of bacteria are infecting a patient that would show up in the UA. And usually we do what's called a reflexive culture, which means if the lab identifies some of these elevated proteins that we see in a UTI, they're going to reflexively culture it. And so we can see what is the actual bug that's infecting this person, so I can give them a targeted antibiotic. Because we never want to give broad spectrum for everything if we don't have to. We'd like to give them something specific so they don't build resistance. So we'll probably do that. But the problem with cultures is they take a couple days to come in, because cultures have to grow. So the first thing we'll do if we think he's got a UTI is we'll do first a UA. We'll see some of those elevated proteins, and we'll start them on broad spectrum antibiotics. Likely that's what we'll do. But does anyone know what the first step we would do if we were to identify a UTI in this patient? Before we do anything, remove the catheter. You're absolutely right. So first, take that catheter out. Starting him on antibiotics when he's got this catheter in that's keeping the infection going is only going to be not helpful for him. So always remove the catheter first. And then if he really needs it, like for instance, in this patient that we've had today, if he hasn't, he has had the catheter in for 3 days, but how did his urine look? Was he doing okay? Do we think we can take the catheter out? Anyone? Yeah, the color was clear. It was light colored, and more importantly, he was producing urine. So I say let's take out the catheter. I think that the longer it's staying in here, if he doesn't have a UTI, he's probably going to develop one. So I say if let's try it. Let's take the Foley out. Let's see if he's able to urinate. If not, we can consider putting the catheter back in. But I say let's not leave it in a day longer than it needs to be in. So that's a great one. Now, here's another kind of important question. Are there any other symptoms that might show up in a patient with a UTI other than like pain with urination? Is there anything else that it can present as? Delirium. Adam, you're right on the dot. How long do catheters typically stay in after surgery? Just a couple of days. We don't like to leave them in as longer than they have to, but it will depend on the surgery. Sometimes it really depends on kind of how well they're doing after surgery. If they're still kind of like if they haven't really been taken off of sedation, then we're going to leave it in. But typically, if it's a quick procedure, sometimes the catheter will go in during the procedure and come right out afterwards. Sometimes we don't even leave it in. It's just for some of these patients with the longer procedures where we might keep them on sedation for a bit after, we might leave that fully in, but we like to take it out as soon as possible. Great question, Adam. But you're right, delirium, fever, and chills. A question that you will see on exams in medical school is an old lady presenting with delirium, and you're supposed to be like, oh, she's got dementia, but she doesn't. She's got a UTI, and she's presenting with the primary complaint of delirium. So that's a great catch. And also fever and chills. If she becomes septic from that UTI, it can present systemically. So UTIs can cause kidney problems in the short term. Yeah, I mean, it depends what you mean by short term, but certainly if you have chronic UTIs or an untreated UTI, one of the reasons that people are like, don't take azo just for symptoms and make sure that you go get actually treated for a UTI is that bacteria can travel up the urethra into the bladder and up the ureters into the kidney and cause what's called pyelonephritis. So, and that can be really bad for your kidneys. You're saying, yeah, no, exactly. This happens all the time. And people are like, oh, he's just got dementia. Like, don't worry about him. Go put him in an old age home. And they just have a UTI and they can clear it with antibiotics. And then they end up untreated and then they get pyelonephritis. So yeah, Adam, it's really stressful and really great as you guys, hopefully as future clinicians, to keep in mind. Why does UTI cause delirium? Great question. So when these patients can quickly become septic from UTIs, especially these older patients, and that sepsis can affect kind of the neurologic system without going into too much detail. But it's kind of a classic symptom that's meant to throw you. And because this happens mostly, like if you're a 20-something, you're probably not going to get delirium from your UTI. You're probably just angry. Like you're not having delirium symptoms. This is classically going to be in like a patient who's in an old age home or something like that. And now they're like symptoms acutely worsened and they're seeing bugs crawling on the wall and they're like, oh my goodness, she's schizophrenic. But they're not. I don't know if I really answered your question, but I am doing my best. Next one, post-op day 5 to 7 is wound. Someone had mentioned this. We have to check the incision. We're going to see surgical site infection, either superficial or deep. So superficial is going to be like the skin around the incision is kind of infected, or a deep infection. I mentioned that mediastinitis, which is that deep tissue infection in the chest, which is very common in sternotomies and extremely deadly. So how would you want to work this up? Or how would we want to start investigating if this were the cause? Check for discharge. Yeah. You guys are all correct. So we want to look for discharge or like pus or something coming from the wound. We have to take the bandage off, something I've seen all the time. And like I myself am guilty of this as well. Going into the room to check a patient post-operatively and I just kind of look at the bandage. I'm outing myself in a big way right now. And I look at the bandage and I'm like, yeah, it looks clean. And I should really be taking the bandage completely off to look. The residents are always coming in right after me. So I justify it by saying like, oh, they're going to come look at it anyway. But really it's better practice to actually go look physically at the wound and then just change the dressing. It's kind of a pain, but it's what you need to do. So always check that incision. It will be like red, puffy, inflamed, maybe pus. Necrosis, it's a little early for necrosis, but certainly we could be seeing some like dead or dying tissue around. Blood culture is a good idea, definitely, if we're thinking maybe sepsis. Blood culture is going to take a couple days to come back, but it can't hurt. How often are bandages changed? You know, it depends on the bandage and it depends on the wound. So like for skin grafts and stuff, sometimes that will stay on for a couple of days. Post-operatively, I think a lot of bandages are changed after like 2 or 3 days. It depends if it's like a wet to dry dressing or kind of what they're doing. Typically, we like to keep that first bandage on for a little bit, just so we're not seeding infection onto like traumatized skin. It varies a little, but I'm gonna go with a couple of days usually. But you're right, Josh, we definitely might want to get a blood culture if we're suspecting sepsis. And something like mediastinitis, it can't hurt. So that way, at least if we start antibiotics, we can make sure that they're targeted. So always, always, always look at the patient, always look at the wound. And for wound, I also want to add here those sacral ulcers that I talked about. Sacrum is at the lower part of your back, right? Kind of where that top of your hip bone is at that level. They actually have sacral patches. There's a more technical name for them that they put on a lot of bedbound patients to prevent sacral ulcers, because it's so common for patients to be laying on their backs chronically, especially if they can't move or they're super old. And they just develop these big pressure ulcers on their back that can become necrotic and they can become septic, and it can be what kills them. So especially patients in like old age homes and things like that. So making sure to check your entire patient, like even if they had just a sternotomy, if you know this patient is bedbound, making sure to roll them over, grab a couple nurses and or your friends and roll your patient over, check their back. If they're diabetic, check their feet, check your patient all over the place, just to make sure that they're not developing these infections. So always think globally about the patient. Just because they had a cardiac surgery doesn't mean that you're not responsible for their whole everything. Does that all make sense? Oh, we could also, if it's a superficial infection, we could potentially culture the wound itself, just like run a swab over it and culture it. But again, I typically, I feel inclined to err away from cultures as a first line treatment, just because it takes too many days to come back. So the first thing we would do here is make sure. So for imaging or something for surgical site infection, if you're suspecting a deep tissue infection, we could actually image that. We could do like a chest x-ray or a CT scan, and we might actually see evidence of deep tissue infection on imaging. So just because it's a surgical infection does not necessarily mean that we're not going to image. Now, I err away from imaging everything, but I think it's important to note that it can be done. And walking. So this is for anything greater than 5 days post-operatively. And this is, we mentioned this already, DVT and PE. So this is a great picture here. Homan's sign. So we have, this guy's got one big red leg. So that means that he's probably got a DVT somewhere up here in the deep veins, causing this leg to swell up and get inflamed. Sometimes it can be really subtle, just like you're noticing one ankle is bigger than the other. So that's why one of the things that you'll see, even for like surgeons who don't like to do a full physical exam on their patients, not to out the surgeons, I'm not adding anyone, but usually what I'll see them do is most of them don't carry stethoscopes, and they'll just walk in. They'll be like, "You doing okay? Are you passing bowel movements?" And then they flip the blanket up and they press on their legs to see if their legs are swelling, and they're looking to make sure that one's not bigger than the other and it's not red, and then they walk out. So always check the legs of your patients. So this is a great thing to check for. And again, this goes back to that very first thing that we mentioned with the wind. If you're suspecting a pulmonary embolus, where did that likely come from? The legs, right? So we might want to image the legs. We're going to do what's called a Doppler of the legs to see if we can see if there are clots in those deep veins that might have traveled up into the lungs as well. So that's even an appropriate workup for walking. And now wonder drugs, also known as what did we do? So this can happen at any time. Could be a drug fever, could be reaction to blood products, and it can happen anytime, but typically these are going to be earlier than later. Some of these reactions are later onset. I will not get into the nitty-gritty of it, but it's always important to consider what is going into the patient. What medications are they on? Have they ever had surgeries before and reacted to the dyes or to the medications, to the blood? Have they ever had a reaction to it? So does anyone know how we would work this up or how we would address it? Anyone? What's the first thing we would do if I thought, oh, he's having a reaction to one of the antibiotics I've been giving him? He's got like hives everywhere. Yeah, exactly, Josh. We're gonna stop the drug immediately. Always the best answer. Stop the drug, and hopefully they'll be fine. So a lot of these reactions are gonna look like anaphylaxis. You might see hives. You might see swelling of the airway. So we're just gonna stop those blood products immediately if that's what's happening. And then we kind of go from there. So that's not a bad one. That's a pretty easy one, but that's why we always ask when you're in medical school and they're drilling you on, oh, you have to ask about family history and smoking history and allergies to drugs. This is why we're asking, to make sure that this doesn't happen and we can catch it before it happens. So now that we've gone through all of the W's, we're back to our sad looking bald guy over here. And we're gonna do our assessment and plan. So we already went through this, and now here are some of the things that I think might be appropriate. We might want to run a CBC CMP. So here we're just looking for elevated white blood cells and things like that, or if he's anemic. We're looking for electrolyte abnormalities. We're gonna probably run a UA just because he's had a Foley in for so long. We're gonna do potentially blood cultures. We always have to do at least 2. I don't know if I really want to do this or not. I don't know if he seems septic to me yet. Sputum culture and gram stain culture. So this means he's going to spit into a cup literally, and we're just going to culture it to see if he's got maybe evidence of pneumonia, because again, he is post-op day 3. We could potentially culture the wound. I also am not a super fan of this. I'm not a super fan of this yet. I would like to do a chest x-ray on him because I think it's cheap, it's easy, and we're checking for consolidation, and I think it's appropriate to DC the Foley as well, or discontinue it rather. And I'd like to start him on something for his constipation. It's been 3 days since he's had a bowel movement. So I feel like it's probably appropriate to start him on some type of laxative. And I think we're gonna keep him on fluids because he's not hydrating. Let me read this question in the chat. Thrombolytics. It does depend on the severity. Thrombolytics are a fine idea, and we can give thrombolytics for so you're talking about DVT. I read that as PE for some reason. So DVT, you're talking about like why are a lot of patients on Coumadin, which is also known as warfarin, I believe. Correct me if I'm wrong, but a lot of patients who are at high risk for developing DVTs or clots will be put on a chronic blood thinner called warfarin, or the generic name is Coumadin. And that's kind of more preventative. That's like why people at risk for heart attack, stroke, whatnot, we put them on a baby aspirin. And that's just kind of to try to minimize their risk of developing these things. But if they actually have a clot, we'll usually give some type of thrombolytic like we would give for stroke in the brain, an embolic stroke, or a blockage of one of the blood vessels in the brain. We can give a thrombolytic for that. We can give thrombolytics for PEs or DVTs. Typically not though. I think it's just that it's such a big drug to kind of be like, I'm going to break up any clots that are there, that if you have any increased risk of bleeding. So especially for this guy, I'm really not super keen about putting him on a thrombolytic. Perhaps definitely a blood thinner because he's post-operative and that's a high risk for clots. But to thrombolyse him means to break up any clots that are there and to make the blood very unlikely to clot in like a big way. And so if he just had surgery and we need him to physiologically form clots because his chest was just ripped open, I'm not keen on this. I see him bleeding aggressively from the wound. I don't know if that answer made sense. Okay, good. But that's my feeling about it. So here's the review. This is me. Just kidding. This is a stock photo. In review, the workup for post-operative fever is typically not done until after 48 hours. I know that I talked about post-op day 1 and 2 for that first one, but sometimes people can emerge from surgery and they can have a little bit of a fever, but it's nothing. It's just the reaction to the anesthesia. So we usually aren't going to start this whole great big workup until after 48 hours. And then the workup should always be guided by physical exam. We're not ordering all the tests because that requires all the money, and hospitals hate giving you their money. So we want to always focus on what the physical exam says. We want to listen to the patient. We want to look at the patient. We want to check the incision, check their back, check their lungs with their stethoscope, check their vitals, and really make informed decisions. So that's kind of what this talk was all about, which is kind of how to look for certain things in your patient and kind of make decisions based on what we're seeing. So what's next for you guys is hopefully you've been filling out that SOAP note as we've been going. I'm sure I covered a lot of the questions as we've been talking. So I hope you've been listening and participating as we've been going. And there should be another case next Wednesday. Are there any lingering questions about the case that you guys want me to address? Or I'm also happy to sit here and talk about any questions you have about medical school or, you know, applying for residency. I'm getting into that now, or anything like that. I'm happy to answer any of the questions. Which of the following would put a patient at risk for aspiration leading to postoperative fever? I can go over the question. I don't know if you know what? I guess we can go through it. I feel like any surgery would be okay. Any surgery would be okay. Let me see. Yeah. I think, does anyone have any thoughts about this question? I guess we can just make it a group discussion before I take over. Anyone have thoughts about it? Or I chose impaired consciousness, but not sure. Okay, yeah, so I think you guys are along the right line. Can you tell me why you thought impaired consciousness was a good direction to be heading in? Like you lose, yeah. No, this is exactly right. Yeah, this is exactly right. I mean, so impaired consciousness can be anything. This can be like people with dementia who maybe are not really able to control their faculties, or even just think of like your friend on the weekend when they binge drank a little bit too much. That's impaired consciousness. I mean, they're not able to talk, walk, eat, drink properly, perhaps. So even any type of intoxication could impair your consciousness. And just think about your drunk friend who can't function. So that's definitely a risk for aspiration, because that just means that you're trying to eat something and then you kind of like like cough on your food or drink or whatever, and then it just goes down. People say like it went down the wrong tube. That would be what that is. So that's definitely a great direction to be heading in for that answer. Aspiration for any specific surgery, I would say no. Just because I'm not really thinking that any surgery in particular should be causing you to develop risk for aspiration. The only one that I would point out would be like a neurologic surgery, because the neural circuits to control swallowing are in the brain. Being on nasal cannula. Avin, tell me how the nasal cannula you think might be putting a patient at risk for aspirating. This is important for me because I wrote the questions, and if they're confusing or if there's more than one technically correct answer, then I want to correct it. So tell me what your thought process is on that one. Not exactly sure. So remember that the nasal cannula is that tube that runs under the nose and that has the two little bits that go into the nostrils, and they put air up into the nose to help patients who like aren't breathing properly. So in my mind, it's kind of two unrelated systems where if we're just blowing air up into the nose, that shouldn't really be affecting the way you swallow necessarily. So I don't really feel that that would be the best direction to be heading in for that answer. But again, if you guys can identify ways that other answers might be more correct or equally correct, I would love to hear it, and I will change those answers on the quiz. While I have you guys here, okay, perfect. While I have you guys here, I just wanted to ask if you have any suggestions or any interest in other sessions kind of along this vein. I typically give talks related to cardiac physiology, cardiac disease. I've done MI, myocardial infarction. I've done EKG reading. I've done heart physiology. I've done cardiac surgeries. Are you guys interested in anything specific? Destina saying EKG reading, pathologic, physiologic hypertrophy of the heart. Yeah, so you guys are thinking maybe like a heart failure one. So maybe heart failure, maybe EKG, anything else? Second vote for EKG. Okay. Are you guys interested in kind of a comprehensive look at the 4 chambers of the heart, the valves, the electrical system, or is that a little? Yes. Okay. So I know that I've given these talks before, but I will maybe see if I can give one again since I feel like I'm seeing a bunch of new people here. So maybe I will try to organize a heart physiology and an EKG talk then in the future for you guys interested in COVID-19. That would be very interesting, Adam. I would have to do a lot of educating myself about that to give a really informed discussion about. But I will definitely let Becca know that there's interested in a COVID-19 talk as well. That's a great idea. So thank you guys so much for your feedback. I hope the session was helpful and interesting for you. Pediatric cardiology, I would love to do, Destine. They have the coolest congenital heart defects, in that. So I might put that in too. That's a great idea. So I'll have those 3 hopefully coming down the line soon. Keep an eye out for those. I hope you guys enjoyed this session and found it useful. I know that I tend to ramble a bit and that I talk a whole lot, but I hope that you guys got something from it. You learned something, you were interested. And I really hope to hear from you guys again soon and see you at future sessions. And, I'm happy to hang back if you guys have other questions about medical school applications, anything like that too. All good. Thank you, Catherine. I'm really happy to hear that. No problem, guys. Thank you so much for coming. You're welcome. That's a great question. I'm a McDreamy girl. I've been with the show since day 1. So yeah, yep. I gotta go with it. I think the newer seasons are pretty weak, to be honest, but I do watch every week because I'm loyal to the show, but it's lost steam. But yep, it's a great show, and I gotta be honest, going through medical school, I feel like I know the show is definitely fake, but there have definitely been, I will say I've answered 1 or 2 like really, really difficult pimping questions when I've been on rotations correctly. And they're like, how did you know that? And I don't want to be shameful and admit that I got it from a Grey's Anatomy episode, but I did. It was like one random actually correct thing that they said. And I said it and they were like, they thought I was a genius, but really I'm just a fangirl. So, it can help sometimes. It was a documentary. I think I said I saw it somewhere and I tried to be really vague about it. Because I didn't, it felt embarrassing for me to admit that I got it from Grey's Anatomy because I would have been laughed at. But it's fine. Next time I think my line's gonna be I got it from a documentary. Be like, I read it in JAMA. Yeah, I just want to sound smart, but I feel like I shoot myself in the foot a lot when I say stuff like I got it from Grey's Anatomy. Meredith Grey said. Thanks, Vivian. I really love talking about this stuff, and hopefully if you guys can come back for one of the cardiology lectures. As you could tell, I couldn't resist bringing some cardiology into this. So those are really where I think it gets the most fun, because that's what I love talking about the most. So I really hope to do that. I would love to do pediatric cardiology. I'd love to do an AKG session for you guys, and I'd love to do a heart physiology session. So I will definitely bring those in the future. Please keep an eye out. Yep, I think it's going to be great. It'll be a lot of fun. I can even try to do that one first, since it seems like we've got a lot of enthusiasm for it. So I hope you guys have a great rest of your evening. And I will hopefully see you guys in future sessions. Thank you guys so much.